I think you can see where I'm going with this. Don't come back. Ultrasound for lower extremity DVT. Just a quick little thing. So I had a cases like this. I feel like I see these a lot. This one was a 39-year-old lady. She had leg pain. It was kind of in her buttocks down to her lateral thigh. She was 3 weeks postpartum, but really no other risk factors. And her leg looks normal. It's not red, it's not swollen, it's not tender in her calf, anything. And when you do straight leg raise, she has pain kind of in her butt going down her thigh. So if you signed in, or you can just tell me, or you can pretend you're listening and when you're not, what do you think is her likelihood of DVT?
Low.
Okay, low. All right, I heard low, we'll take consensus low. And I put this on here, DVT risk calculator, it just goes to the wells. I think most of us use Gestalt, which is perfectly appropriate. Probably good for us to teach our residents to use the wells to help them develop their Gestalt. And remember, wells does not truly apply in pregnant, cancer, or hospitalized patients. So just a little bit more about her. She was seen the previous night. She had a negative point-of-care ultrasound for DVT, but told to come back the next morning. You got to come back tomorrow to get the word I hate, formal, let's say comprehensive or consultative ultrasound study. All right, so I'm just going to use that to jump into a couple of the guidelines that I use to do this and what I try to teach the residents a little bit. And these are new. I didn't know about these. These came out last year. This is from the American Society of Hematology. So I adapted some of the stuff I usually go over from this, but they're very similar to the chest guidelines, but they haven't been updated since 2012. The new hematology guidelines are probably a little easier to get through and digest. So most of my info comes from this. It's pretty evidence-based. So one thing that both of these guidelines talk about is they don't differentiate a proximal leg ultrasound versus a whole leg ultrasound, and that's in vascular labs. Here, our vascular lab, they pretty much always do the whole leg. But in other vascular labs, it's not uncommon that their DVT study is just the proximal leg. So I think that's an important point to keep in mind when we're talking about what we do. And then there's pretty good EM literature that says if you do a quality, and I'm going to get to the caveats of what a quality DVT point-of-care ultrasound is in a second, that's pretty much equivalent to the proximal leg ultrasound. And so just my kind of truncated, abbreviated algorithm is first assess their likelihood. I think sometimes things are busy, we're trying to go quick, and we just say, oh, get an ultrasound, and we don't think, are they really high risk, low risk, moderate? And having a risk factor does not mean you're high likelihood. High likelihood is risk factors and presenting symptoms and findings. So, and we only care about negative, right? If it's positive, we know what we're going to do. We're going to treat them, so I'm not going to talk about those. But if they are low likelihood and you have a negative point-of-care ultrasound, quality point-of-care ultrasound, you're done. They don't need anything else. No follow-up, no serial ultrasound, nothing. That's guideline-based. That's what the guidelines say.
Okay, hold up just a second. Now, that's not exactly what the guidelines say. What the guidelines say is a proximal leg ultrasound in a low-risk patient is adequate to discharge them with no follow-up unless they have new recurrent symptoms. So the guidelines don't actually say a point-of-care ultrasound, but I'm making the case that if you do a quality point-of-care proximal leg ultrasound, it is essentially equivalent to any proximal leg ultrasound that's done anywhere. Carry on.
If they are moderate risk and they have a negative point-of-care ultrasound, quality done, maybe a repeat in a week. So they don't need to come back the next day, 48 hours, it's a week. And they're high and they have a negative point-of-care ultrasound, still repeat in a week. That's it. That's all they need.
I'm going to jump back in with another quick caveat here. If for some reason it's a high likelihood patient and you're truly suspicious that they have like a proximal DVT, say iliac or something in the pelvic veins, then maybe you're not done. Maybe you need other imaging with CTV or MRV. Luckily, that's pretty rare, but it is possible, so don't completely forget about the pelvic or iliac DVT that could be happening. And these patients are going to look for all purposes like a DVT, where maybe you don't see it as easily on ultrasound.
So just a couple of thoughts. All the guidelines talk about D-dimer first, then ultrasound. That's kind of stupid when you can do the ultrasound in 5 minutes and the D-dimer takes an hour. But if you have somebody and you do an ultrasound, you're like, oh, I feel a little uncomfortable, you can add a negative D-dimer to give you more comfort level. So that's something to consider that keeps the patient from having to come back and clog up our ER the next day. I don't do that, but that's something to think about. If the D-dimer is positive, it's overruled by a negative ultrasound. So if you've already done a negative ultrasound and you're comfortable enough with that, then the positive D-dimer is not going to add anything. The negative might make you feel better. Questions on the D-dimer? I feel like we don't talk about D-dimers and DVT much because we usually just go right to the ultrasound, but that's widely accepted in guidelines to use that. Even our residents, when I say D-dimer, they say, oh, if it's positive, they have a PE. It's any VTE, so we could probably do a better job with teaching our residents that a little bit. And one thing I want to say about high likelihood, now this is where I'm veering off of evidence-based guidelines a little bit. High likelihood is somebody who looks like DVT, right? They got a red, swollen, probably warm leg and some risk factors. Those people have a lot of clot burden. You're probably going to see that on point-of-care ultrasound. Now the caution is that's minority's opinion. There's no good evidence to show that. But from lots of studies and lots of cases you see, when their leg looks like DVT and they have it, you see it because they have big clot burden. It's not this little distal DVT that's hiding in their distal femoral vein somewhere. So I'm comforted by that, but that's opinion, so proceed with caution.
And for those of us that may not be as comfortable, I mean, if you do get that positive ultrasound in formal radiology, such I didn't have a stroke, but I mean, just like when somebody sees something on a CAT scan that you don't see, you go back and try to find it.
Yeah.
Yeah. To me, I think there's probably a lot of opportunity for the residents and ourselves to go, oh, there's a DVT there. Let's go find it and take that time to learn what a positive looks like. If either A, you missed it first time around, or B, you just need to.
Yeah, you just know it.
Didn't do it. So
that's how I taught myself most of ultrasound, was going back and dog chasing an ambulance to positive studies on CAT scanning or whatever. But if you want to look, these are the guidelines that come from hematology. I'm not going to go through them in a lot of detail. Essentially, if they're low likelihood, if you want to do a D-dimer, it's negative, you can be done. If the D-dimer is positive, proximal or whole leg ultrasound. If that's negative, you're done. There's no follow-up. They don't need serial, nothing. Moderate is about the same. D-dimer, kind of skip that. But if they have proximal or whole leg ultrasound that's negative, then they can get serial. And that's in a week. Serial is defined by another study in a week. Not next day, don't come back to the ED. Then high likelihood skips the D-dimer entirely. But they still don't differentiate proximal whole leg ultrasound. So if it's negative, then serial, and serial's in a week, negative, it's positive. Or you have the option to say it's no and kind of assess some other risk factors and decide. So that they leave some leeway in that high likelihood, but it skips the D-dimer entirely. So just again, reminder take-home points: proximal leg, pretty much equivalent in the guidelines to whole leg ultrasound. If you do a quality DVT POCUS, and I'm going to go over that quickly, same as a proximal leg ultrasound. And so here's what a quality POCUS is. You got to get the saphenofemoral junction, so that's way up in their groin, where you're going to feel like uncomfortable where you're putting your hands next to the patient, and you got to find that junction. Then you got to follow that down until you see the common and deep femoral junction. I'm going to show you pictures of that. And then the popliteal, you got to find the popliteal and track it proximal and distal until you see, basically you just see branch points. I don't really try to identify each individual vessel. I just find the branches from the popliteal, proximal or distal, and it's really variable in patients if it's up or down. So here's the quality, here's the anatomy. So we got to get up high enough, and this is right up in the inguinal crease, so flatten them out if you can, so you can get up there and kind of peel back layers if you have to, and find the saphenofemoral junction. The saphenous vein comes in medially and superficially to the femoral vein. Follow the femoral vein down until you see it split vertically, and I'll show you a picture of that, to the common and deep femoral veins. And then I usually just then follow the femoral vein as far as I can until I lose it in the adductor canal. And then when you get to the popliteal, really just get right in the crease, peel back layers, apply some pressure, make sure you're deep enough, find the popliteal vein, and then track it proximal and distal until you see the branch points come off. And make sure everything that's not an artery is compressing. You don't have to identify that's anterior tibial, you don't have to do that. Just anything that's not an artery compresses. So just a reminder of what these look like proximally. So this is someone's right side. So the artery is lateral, the femoral vein is deep and medial, and the saphenous vein comes in superficial and medial. So that's what that's going to look like. And then you compress them, and everything should compress except the artery. And then if you look on other sides, just remember mirror images of each other. But that's your highest point. You get there, then you work your way down. As you go down the leg, just keep the artery as a guide. You'll see the veins split vertically. That's your deep and common junction, and this is a little better illustration of that, I think. The vein is here, and you see the deep femoral vein. It comes down vertically right below it. And it dives down quickly, and you lose it quickly because it goes straight down the leg. So just as a little diagram, it kind of looks like this. The artery's up here, the vein's there, and you'll see that vein split vertically, but then it dives down and you lose it. But it's really only about that far from the saphenofemoral junction. It's not far at all. And then just follow the femoral vein, make sure it compresses as far as you can see it. And then when you get to the popliteal, you're going to see the popliteal artery deep. The vein's usually on top, but sometimes it's off to the side a little bit. You'll see the nerve and some other superficial veins. And then you can compress that. And everything that's not an artery should compress. So you don't need names or anything. And then if you just track it up and down, you should see the different branches of the trifurcation. I just look for branch points and make sure they all compress. But if you want posterior tibial and peroneal and then anterior tibial, fine. You can name them if you'd like. But they should all just compress. Everything that's not artery compresses. And then just the last thing, if they're like, oh, I got a red swollen spot on the medial part of my calf, just go look at that. If they have a clot there, you're going to see it. You might have to track it and see if it's superficial or deep or not. But look at any localized area that looks concerning on their leg. So, quick summary, assess their likelihood first. If they're low, negative POCUS is enough. If they're moderate, negative POCUS is probably still enough with a repeat in a week, not a next day. And high, it's really same thing. And remember, the quality is saphenofemoral all the way down to all your junctions and popliteal to the trifurcation. And if we kind of do this, I think it's a pretty patient-centered way to get one. We can go in, ultrasound, kick them out. I love these, 5 to 10 minutes, and they're gone. And then if we can stop telling them to come back the next day, because that just clogs us up, wastes time. Patients don't like it, and that's all I got.